In this lecture, we'll be discussing about the investigations that we do in a case of hemolytic anemias. Now, the broad differential diagnosis of anemia could be microcytic anemia, normochromic normocytic anemia, and macrocytic anemia. Most of the hemoglobinopathies come under the normochromic normocytic anemia or the microcytic hypochromic anemia. The major differential diagnosis of hemoglobinopathies is iron deficiency anemia, and the features that we look for is that increased RDW, that is red cell distribution width, presence of anisopoikilocytosis, increase in platelets, a normal total RBC count. All these will favor the diagnosis of iron deficiency anemia. On the other hand, if the red cell distribution width is not increased, the Menzel's index is less than 13, presence of schistiocytes, polychromasias, normoblasts, all of them will suggest that we're dealing with hemoglobinopathies or hemolytic anemias. Soft markers suggesting hemolytic anemia will be a presence of increased in the serum LDH levels. Now, the Menzel's index, as we talked about, it is a ratio of the mean corpuscular volume divided by the total number of RBCs. In hemolytic anemias, we have microcytosis. We have increased production of RBC to compensate for the destruction of the RBCs, so the TRBC numbers increase. That way, MCV divided by total RBC, if it is less than 13, would be suggestive of thalassemia. Presence of schistiocytes. These broken RBCs would also favor the diagnosis of hemolytic anemia. When the RBCs are being destroyed, the bone marrow tends to work overtime and push immature RBCs into the circulation, and this is manifested by cells which have a slight bluish color called polychromasia. This is a smear showing lot of schistiocytes. Another feature that we would see in hemolytic anemia is presence of these normoblasts. Now the nucleus may look like that of a lymphocyte, but look at the cytoplasm. The cytoplasm is abundant and the cytoplasm has got coloring tinge, the cytoplasmic characteristic is more showing about hemoglobinization and relates to the RBC. So you see that there is hemoglobinization occurring, and that's how you'll differentiate this from a lymphocyte. A thorough examination of the peripheral smear can also give us some telltale signs about the RBC morphology, which could be accounting for the hemolysis. Like if you look at these cells, round cells with lack of central pallor, round cell with lack of central pallor. Similar features you can see over here that these cells lack the central pallor. There are some RBCs showing central pallor, indicating that the smear making is not abnormal. But when you see schistiocytes, when you see polychromasia, and when you see RBCs with lacking the central pallor, we will tend to think about cell membrane abnormalities like hereditary spherocytosis. And other feature, sickle cell anemia. You can see this classical sickle cells, and the important differential diagnosis of the sickle cell is pencil forms, which you can see in iron deficiency anemia. The point of importance is look for the central pallor. Absence of the central pallor in multiple such cells would suggest that we are dealing with sickle cell anemia. Polychromasia, as I said, was a response of the bone marrow to push in more RBCs to compensate for the RBC loss. You will get a faint discoloration, and that's why your staining of your slides should be very important. Normally, the reticulocyte count is less than 2%. The reticulocyte count is done by taking equal amount of blood and the reagent, incubating for about 20 minutes. The reagent, that is methylene blue, precipitates the RNA. The slides are fixed and then studied under the microscope, and we explain and we count reticulocyte as number of reticulocytes seen per 100 RBCs. This is the polychromasia we are talking about, and this is how it would stain under the reticulin stain. You can see the reticulocyte stain. You can see these coarse granules in the immature reticulocytes and fine granules in the mature reticulocytes. So, when we are dealing with a case of hemolytic anemia, we have three differential diagnoses with us. Are we dealing with hemoglobinopathies? Are we dealing with RBCs with membrane defects? Or are we dealing with RBCs with enzyme defects? The most common would be the workup for hemoglobinopathies. To do hemoglobinopathies, first we should know the normal distribution of the various hemoglobin fractions. The major thing that we are bothered about is the HbA, which will usually be about 95%, HbA2, which will be less than 3.7%, and HbF, which will be less than 2%. Remember that in newborns, HbF can be almost up to 80%, and by 6 months, greater by 6 months, it reaches a figure of 1 to 2%. The most common method for diagnosing hemoglobinopathies would be agarose electrophoresis. For that, we have to make a hemolysis. It's like a protein electrophoresis where we are doing separation of the hemoglobin. So we have to remove all the plasma proteins. That's why we take 1 ml of blood, add about 5 to 10 ml of normal saline, mix it up properly, centrifuge so that all the RBCs settle down, discard the supernatant. Once again, add 5 to 10 ml of normal saline, mix thoroughly, let it stand and centrifuge. You repeat this 4-5 times so that all the plasma proteins are removed. Then to the bottom, after the last step, when you centrifuge it and you get all the cells precipitated in the bottom, add a drop of water. This will cause the destruction of the RBCs and the release of the hemoglobin. Now, add chloroform. uh, Maybe about an ml of chloroform is good enough. Add chloroform to this hemolysate and centrifuge it. You will get three distinct layers. The bottom layer is of the chloroform. The top layer, which is the aqueous layer, which will be bright red in color, which is of the hemoglobin. And in between, you'll get a layer which will contain all the stroma and cellular debris. Take out the hemolysate, and this is then applied to the agarose gel for electrophoresis. HbA is the fastest moving band and gives a band. HbF comes slightly behind it. This is the band where the HbS would usually be there. There is HbA2, and if you notice, there is a faint band over here which corresponds to carbonic anhydrase. So in a normal agarose electrophoresis, you will get the HbA band, which is the fastest moving. Just behind that is the HbF band. The index whether your electrophoresis is good or not is to check your ability to differentiate HbA and HbF. Behind HbF is HbS, and behind that is your HbA2, and in between the point of origin and the HbA2 band, you could find a fine band of carbonic anhydrase. Now, this is a form of protein electrophoresis. The point you need to keep in mind is in the region where the S band is, sometimes you can also get band from HbD and HbG. Similarly, when you get a band in the A2 region, this could correspond to HbC, HbA2, HbE also. HbA2 is what is normally present, but HbC and HbE, if they are present, they would also present in the same region. The important point over here is that in a normal person, you do not have HbA2 levels going more than 10%. So if you get a HbA2 concentration more than 10%, you're dealing with a hemoglobinopathy, probably C or E. HPLC can also be done using ion exchange chromatography. The D10 platform of Biorad, fully automated and process, which is there in most of the labs, it gives us quantified values of HbA, HbA2, HbF, and it has also got certain windows, the S window, where you could see sickle cell anemia. It can quantify some amount of the hemoglobins and tell you what type of hemoglobinopathy it is. However, If you want an accurate diagnosis of the hemoglobinopathy, the best machine would be the minicap or Sabia's capillary electrophoresis. When you do hemoglobin electrophoresis, in this capillary electrophoresis, you nearly get about 15 zones where you can see the bands which get quantified, and the instrument has got a very good database to actually characterize which kind of hemoglobin it is. And a major advantage of the capillary electrophoresis is it can also detect HbH, which would be missed in the Biorad D10. There could be a lot of debates between whether HB, HPLC or HB electrophoresis, between the two, which is the better one. But both of these are good enough techniques to diagnose hemoglobinopathies. Coming to the next thing, working up for membrane defects. On a smear, you would be able to see these spherocytes. And when you see these spherocytes, you think it could be hereditary spherocytosis. And to prove the hereditary spherocytosis, you need to do what is called an osmotic fragility test. A very simple screening test that you can do in your lab without very much of an infrastructure is take normal saline and make various concentrations of normal saline. Now, how do you do it? You take 9 ml of 0.9% normal saline, remove half an ml and add 1 ml of water. You will get a 0.85% normal saline. From the 9 ml of normal saline, remove 1 ml and add 1 ml of water. You will get 0.8%. And like this, you can make the entire series of dilution starting from zero point 0.9 right up to 0.0. After you've made this, make two such sets, one for a control and one for your patient. Now, after you've made this, take blood 50 microliters of a normal patient. Now, it is very important that the amount of blood that you put in each of the tube should be consistent. Put 50 microliters of whole blood in all these test tubes. Similar way, put 50 microliters of the patient's blood in all these test tubes. Wait for about half an hour's time. This is the time when the RBCs will lyse. After half an hour's time, nicely mix up all the tubes, centrifuge it properly. When the RBCs are intact, as you see in the 0.9 and the 0.85% normal saline, the RBCs will be intact. They will settle down as a button and the supernatant will be clean. But as the RBCs, as the concentration of the sodium chloride decreases, you will find that slowly hemolysis starts occurring. And beyond a particular level, you will find that the hemolysis has occurred maximum. So the zero test tube, the optical density which you get at the zero test tube is considered as 100% hemolysis. The optical density which you get at the 0.9 is considered as zero. And the optical densities of each of these concentration of sodium chloride is expressed as a percentage. Once again, you've made a series of dilutions of sodium chloride. To each of that, you've added fixed volume of blood. That could be 50 microliters. You let them incubate for about half an hour, centrifuge, and find the optical density of the supernatant. The optical density of the zero tube, that's pure water, where 100% RBC has got lysed, that will be considered as 100%. The optical density of the supernatant of the first tube, that is 0.9% sodium chloride, where the RBC lysis does not occur, that supernatant optical density will be considered as 0%. And the optical densities of all the supernatants will be expressed as a percentage. We do this for a test, we do this for a control, and we do it for a test. And then we plot a graph between percentage hemolysis and the concentration of sodium chloride. We detect at what concentration of sodium chloride did we get 50% hemolysis. So you see, in the control, at 0.55% of sodium chloride we got 50% hemolysis, whereas in the affected case even at 0.65%, we got 50% hemolysis. You can see that the hemolysis is starting in this tube at 0.75, whereas the control is not showing hemolysis. This indicates that there is some problem with the membrane integrity and these cells are lysing at an earlier time. So this is the principle of osmotic fragility test. Now workup for enzyme defects. The key enzymes that we look for is G6PD deficiency and pyruvate kinase. Pyruvate kinase deficiency is known to cause hemolysis but done in very few labs. G6PD is something which is more common and is a part of a neonatal screening protocol, and definitely in cases of Plasmodium vivax where they want to treat with primaquine, you have to get a G6PD test done. Now, the qualitative test, which is done in most of the labs, is the sodium nitrite methylene blue conversion test. Now, the principle of the test is that sodium nitrite converts hemoglobin to methemoglobin. When we add methylene blue stimulates G6PD enzyme and induces the production of NADPH. The NADPH so produced converts the methemoglobin back to hemoglobin. So what we're doing is we're taking three test tubes. The patient sample itself is used for test, for positive control and for negative control. Take 1 ml of the patient blood in each of these test tubes. In the positive control, just add sodium nitrite and incubate for 10 minutes. In the negative control, just add methylene blue and incubate for 10 minutes. And in the test, add sodium nitrite, add methylene blue, and add sodium nitrite, methylene blue, and the blood. Mix all of them. So what's going to happen is after 10 minutes, the volume is made up to 10 ml so that we can with normal water so that we can read the optical densities. In the first test tube, we've just put the blood of the patient and we have put sodium nitrite. So all the hemoglobin has been converted to methemoglobin and this appears dark. In the second test tube, we have taken the patient's blood, we put methylene blue, but we have not added sodium nitrite. So there is no conversion, spontaneous conversion to methemoglobin. So this becomes your negative control and this becomes your positive control. In the test, we are adding sodium nitrite that forms the methemoglobin. We are adding methylene blue, which induces the production of G6PD enzyme, which induces the action of the enzyme G6PD, which would induce the production of NADPH. If the enzyme activity is adequate, all the methemoglobin will get converted to normal hemoglobin, and this will resemble more of the negative control. So if the optical density of the test resembles the optical density of the negative control, then we know that this patient does not have G6PD deficiency. On the other hand, if we add or methylene blue and the color doesn't come back to normal, as you see in this case, this is your positive control, this is your negative control, and this is the patient sample, and you see that the color is now matching more towards the positive control, indicating that this patient has G6PD deficiency. Nowadays, we have kinetic methods which can estimate the conversion of NAD to NADH using 340 nanometers, which can be done on automated platforms. But most of the labs do this test for confirming G6PD. A small important rider to this test is the timing of the test. Usually, when you suddenly see a person's hemoglobin falling down dramatically following some stressors like Ajinomoto is the most common thing that can affect. Primaquine as a drug can cause oxidative stress and cause hemolysis. So when you have a sudden drop in hemoglobin, that is the time when the clinicians in a knee-jerk response say get a G6PD test done. Remember that following an acute hemolytic event, all the cells that didn't have G6PD enzyme, those cells which had G6PD deficiency, all of them would have been destroyed. The RBCs that have survived this insult are the RBCs which have some amount of G6PD in them. As a result, immediately following hemolysis, if you do the test, you will falsely get a report suggesting that there was no G6PD deficiency. I once again reiterate this point. The patient has G6PD deficiency. There was an acute hemolytic crisis. The hemoglobin has fallen down. The RBCs where the G6PD enzyme level was very low, all of them have already got destroyed. What has survived in the system are those RBCs which have some amount of G6PD activity. That's what has survived the insult. So when I do a G6PD test in these RBCs, I'll erroneously get a report that there was no G6PD deficiency. Need to repeat this test after 2 months so that the original population of the patient's RBC once again populates the peripheral blood, and then we should check up for G6PD deficiency. The same problem occurs because we've seen that many of the people have a crash in hemoglobin immediately as an emergency response treated with blood transfusion, and then they send the blood for testing G6PD deficiency. Here, we will tend to test the G6PD deficiency status of the donor blood and not of the patient's. So that is another problem. If a patient is to be given transfusion, collect the blood before the transfusion tested. That is the patient's innate blood. The moment you transfused it, all the results, be it G6PD test, be it HbA1c, or be it the hemoglobin electrophoresis, or be it even the membrane defect studies, all of those results will be wrong because you'll be testing the normal blood which has come from the donor. So be careful about the timing of the test also. Thank you very much for a patient hearing.